I'm Christopher Fox, the Chief Executive Officer of the International Association for Dental Research. Today, I'd like to talk to you about dental, oral, and craniofacial research and the global burden of disease. It's my pleasure to be with you here today at the International Federation of Dental Hygienists Global Oral Health Summit. I bring greetings from our IADR President, Pamela Den-Beston, from the University of California, San Francisco, who sends her best wishes for a successful summit as well. What I'd like to cover today is global oral health, both from a disease burden and an economic burden perspective, what we mean when we talk about global oral health research, research advocacy, and the role of IADR. Before I get to the formal agenda, I want to talk about two items that are new, breaking news, which hopefully all of you have heard about by now. But last month, the World Health Organization passed an oral health resolution at the World Health Assembly. And this came about driven by Sri Lanka and had over 40 other supporting member states and a broad coalition of non-state actors that supported this oral health resolution. The resolution calls for a global strategy in 2022 and a global action plan by 2023, including best by interventions on oral health as part of non-communicable diseases and for oral health to be integrated into universal health coverage. I would encourage all of you to go to the WHO website and read the oral health resolution. So IADR, along with the FDI World Dental Federation, are in official relations with the WHO, and this allowed us to make a statement in support of the oral health resolution. But we were also joined by a variety of other non-state actors, including Smile Train, the International Society of Nephrology, NCD Alliance, World Health Federation, the International Diabetes Association, or Federation rather, and the World Stroke Organization. And this really taught the other organizations that joined us really recognize the importance of oral health and general health and those associations and linkages between, which is why they came together with us in support of this resolution. The second piece of breaking news is that some of you, particularly those of you who may be based in the United States, will have heard by now that in 2018, the US Surgeon General, then Jerome Adams, had commissioned what was going to be the second ever Surgeon General's report focusing on oral health. There was an administrative transition in 2020 in the United States, and this means that the NIH and the NIDCR will now be issuing this report, and this is due out in the fall of 2021. This was announced at the end of May by Dr. Rena D'Souza, the new director of NIH and NIDCR. And the report will be called Oral Health in America, Advances and Challenges. It will be talking about new directions in treatment of oral diseases. It will be identifying disparities and inequalities in oral health care, and it'll propose innovative strategies to ensuring all Americans share equally in the benefit of oral health. And while this is a US-centric document, it will have global implications, and I would encourage all of you to be looking out for that publication and accessing that when you are able. So let's get to the formal agenda and talk about the disease burden of oral health. 3.5 billion people, which is a number we like to throw around a lot. That is the number of people impacted by oral diseases this is from the Global Burden of Disease study in 2015, looking at disability adjusted life year. The number one disease or condition affecting populations was untreated caries in the permanent dentition, followed by untreated caries in the deciduous dentition, severe periodontitis, tooth loss, and other oral conditions. Sum this up to 3.5 billion people. That's roughly half of the world's population. So we certainly have the morbidity as it relates to oral diseases. And due to the aging of the populations and the fact that we haven't really been able to tackle oral diseases as much as we would have liked to over this 25-year time period, it's actually increased. In 1990, it was only 2.5 billion people, now 3.5 billion in 2015. So if you look at mortality, and this is data from the University of Washington in Seattle Institute for Health Metrics and Evaluation, the number one disease in 1990 in terms of mortality was ischemic heart disease, and it stayed the same in 2019. So oral diseases are really not on this list of diseases and conditions that impact mortality. But if you switch your thinking to morbidity, here oral disorders are the number one condition in 1990, and it remains the number one condition in 2019. So So obviously not showing the type of progress we would like to see as it relates to oral disorders. So that's mainly caries and to a certain extent periodontal disease, but also looking at oral cancer. This is data from the International Agency for Research on Cancer out of the WHO. And here you can see that last set of bars at the bottom, lip and oral cavity. Incidence is the blue bar and mortality is the red bar. So this is looking at just males, but we know that oral cancer varies by geographic region related to habits of betel nut, areca nut chewing tobacco. And if you look at just Southeast Asia, now lip and oral cavity is the number two cancer in this population amongst males, followed only by lung. And then if you drill down even further to just India, lip and oral cavity cancer is the number one cancer in India. The blue bar again is incident, the red bar is mortality amongst males over the age of 20 in India. So that's caries, periodontal disease, and oral cancer. This is looking at birth defects, and cleft lip and palate is actually the second most common birth defect amongst live births, followed only by trisomy 21 or Down syndrome. This is looking again from the Global Burden of Disease studies at the prevalence of severe chronic periodontitis in 2010. And you can see countries in red having the highest levels of severe chronic periodontitis, followed by the orange, yellow, green, and then blue by country in terms of chronic periodontitis. So hopefully I've been able to demonstrate that oral diseases do present a significant disease burden to populations. They may not have the mortality that cardiovascular disease has, but in terms of morbidity and percent of the population impacted, it is very, very high. Let's talk about economic burden, and this is US data looking at national health expenditures in 2019. The overall health expenditures across the whole country was $3.8 trillion in this time frame, or about nearly 18% of the gross domestic product, or 11,500 per person. The U.S. spends by far much more than any other country, much more than any other high-income country, and it's been growing at about 4.5% each year. Dental, as part of that, is $143 billion, so that's about 3.8% of our overall health expenditures, and that's growing also at a little bit over 4% versus 2018. But the major difference between oral healthcare and the rest of healthcare is a much higher percentage of it comes directly out of pocket from patients, from consumers. So this pie chart shows in that lighter blue that 42% of dental expenditures are coming directly out of pocket from patients and not covered by any sort of government or even private healthcare scheme. Looking globally now, this is again referring back to the Global Burden of Disease studies. This is a report in the Journal of Dental Research from Stefan Litz, one of our members and a brilliant health economist, looking at direct treatment costs due to dental disease, and they estimated on a global worldwide basis that in converting that into US dollars, it's almost $300 billion on direct dental treatment, or about 4.6% of global health expenditures, very consistent with some of the US data. And then if you add on top of that the indirect costs due to dental disease, actually lost work hours, that's another $144 billion. So the total global economic impact due to dental diseases in this time period of 2010 was estimated to be $442 billion. So that's the disease and economic burden. Let's talk about what we mean when we talk about oral health research. And when we talk about any research in general, we're talking about everything from the discovery stages of basic discovery, preclinical research, in vivo analyses, translating that research in terms of proof of concept studies, if the drug or intervention looking at pharmacodynamics and toxicology, the clinical research that is needed to get the various regulatory approvals, and then if it is approved, how do we translate and adopt that into practice, the practice guidelines, community assessment, health services research that's needed, and then at a higher population level, global health, how do we really improve the entire community's health status with the research findings in terms of global health services and research. This is a diagram that presents research in a very linear fashion. This is adopted from a report by Victor Zhao in The Lancet when he was at Duke Global Health. He's now the director of the National Academy of Medicine. Another way to look at this same sort of research enterprise is this version, which is from the National Institutes of Health NCATS, Translational Science Spectrum. And this is looking at it not so much in a linear fashion, but how all the interconnections, which is really more realistic in terms of how research actually happens. And yes, we may start with basic research, which will go to preclinical research, clinical research, implementation research, and benefiting public health. But there are many more interconnections along the way where basic research may directly inform public health. There may be a direct connection between basic research and clinical implementation, how we disseminate these findings, demonstrating their usefulness, and developing new approaches to health promotion and disease prevention. So in terms of dental, oral, and craniofacial research, oral diseases remain the most prevalent condition affecting populations. And we know about the inequalities that exist in oral diseases, that subgroups are very much disproportionately affected, with 25% of the population, for instance, having 80% of the dental caries burden. So, really for these reasons and these reasons alone, we think we can build a strong case for why we need dental, oral, and craniofacial research. But there's a much broader research agenda in addition to all of that. So we know that the oral cavity is really a diagnostic window to the body. Saliva can be used as a diagnostic and monitoring tool in terms of point-of-care diagnostics. We're finding that out right now with COVID-19, the usefulness of saliva as a diagnostic tool. Oral health is part of general health and all the connections and associations between oral health and stroke, oral health and cardiovascular disease, diabetes, obesity, smoking, and cancer, personalized oral health care, the oral microbiome in health and disease, and how we can use those research findings in terms of enhancing prevention, the impact of tobacco on oral health, and not only traditional combustible cigarettes, but also the newer technologies with smokeless tobacco products, e-cigarettes, and the enhanced nicotine delivery systems. They look like little USB sticks, unfortunately, and addicting our children and teenagers to nicotine at a young age. Enhanced tissue regeneration approaches. How do we more naturally replace lost tissue due to periodontal disease? Improved restorative approaches and materials are drastically needed. Our approaches to cleft lip and palate, HPV-related oropharyngeal cancer on the rise, and implementation science. How do we get all of our research findings into practice that really benefits populations? And COVID-19 has generated an entire new research agenda for us as well. And that too is everything from basic science, where we're looking at the oral tissues as a potential site of infection, as a reservoir for SARS-CoV-2 virus, potential for transmission. And then in our clinical settings, how do we mitigate the generation of aerosols in the oral health care operatories? What are the oral manifestations of COVID-19? And then airborne transmission. We now know that we need to be looking at our dental operatories or dental surgeries, whatever you call them in your country, as really a healthcare facility. And we need the hospital grade engineering controls in terms of the air exchange rates and making sure we've got the right ventilation when we're delivering healthcare. And then dental professionals can be used as vaccinators. The American Association for Dental Research, the American division of IADR, advocated the U.S. Health and Human Services to allow dentists and dental hygienists and dental therapists to be able to vaccinate populations either in their offices or as part of these mass vaccination sites. We got a sort of a partial win on this, and in the middle of March of this year, the Assistant Secretary for Health announced this Seventh Amendment to the PrEP Act, allowing dentists and dental students with appropriate training to be able to deliver COVID-19 vaccine. So it was a partial win, and I know that the ADHA and others, including ADR, are very supportive of expanding that even more healthcare professionals like hygienists to be able to provide vaccines. And there are a number of states, this is the US federal level, but there are some states that allow dental hygienists to be part of that team that are vaccinating the population. So we really want to integrate oral health into overall health. And it's not just dentistry that is sometimes divorced from the rest of healthcare. We know that mental health, vision, hearing is often separate from the rest of healthcare as well. So you may hear people talk about, we need to reconnect the mouth to the rest of the body when they're talking about dentistry and the rest of healthcare. It's almost like we really need to reconnect the whole head to the body because of all these other services that are somewhat separate in different systems than other healthcare systems, including the treatment of kidney disease and stage renal disease. So the individual, we want to always keep patient-centered research at the center, existing in a community, and we have to be cognizant and bear in mind all the social and commercial determinants of health that are bombarding this individual. We need to be paying attention to the healthcare workforce and what the various health coverage schemes are across various health conditions, and then all this exists where we can do the research as the person ages across time, and to be really looking at health outcomes and how can our research really inform to improve health outcomes of populations. Talking about research advocacy, and when we're talking about research advocacy, and we like to do this and provide the tools available to our members around the world to be advocating on behalf of researchers on why research is needed. And when we talk about research advocacy, we need the individuals to actually do the research. They obviously need the proper infrastructure, the laboratory settings, whatever the research may be, the IT equipment, et cetera. Funding for research for both the equipment and supplies, as well as the salaries of the researchers. Scientific exchange is very important. And then how do we get that research findings, the information transfer to both patients and professionals? So we need a pipeline of researchers. We need a curriculum and facilities and a real culture of research in all of our academic settings. We need to have a research agenda with priorities. We're always going to have more research questions than we have funding, so we need to prioritize the research agenda, exchange that information through meetings like the IADR General Session, like the meeting you're having with this Global Oral Health Summit, and publications, and then information transfer. And it's not just to the professionals. We know that consumers are great at Googling and finding out all about their oral health, as well as other health conditions, and coming into our practices with a list of questions that we need to be prepared to address also. So let me just spend the last few minutes of my time here on IADR. Our mission is to drive dental, oral, and craniofacial research for health and well-being worldwide. Our vision is oral health for the world through discovery and dissemination. And our IADR value statement is 3 core areas: scientific excellence, social responsibility, and then supporting the scientific community that is doing this research. We have over 10,000 members worldwide. Our largest region is the North American region, followed by the Pan-Asia Pacific region, followed by Pan-European, Latin American region, and Africa, Middle East. More important than geography, though, are the scientific disciplines. We have 32 different scientific groups and networks. Many of the dental hygienists that are involved in research are members of our oral health research scientific group, but they're also members of you can be a member of any of these scientific groups and networks, including Cariology or Periodontal Disease, Evidence-Based Dentistry Network, et cetera. I saw in your program that Dagmar Elsie Slot is also speaking to you at this summit. She is one of our members that's involved in our oral health research group and Cariology, I believe, and is also finishing her second year on the IADR Board of Directors. IADR has been very involved in global health really since its founding over 100 years ago now. We just celebrated our centennial in 2020. But more recently, over the last 10 or 12 years, we have formed a new network called the Global Oral Health Inequalities Research Network, and this was under the leadership of then IADR President David Williams. And we have a research agenda to address inequalities both within countries and between countries. We publish a lot of the global burden of disease studies that I covered at the beginning of this presentation. And we really find it's really our duty and core responsibilities to be addressing global oral health and the inequalities that exist. If you are a member of IADR, you get a number of benefits, including access to our 2 journals, the Journal of Dental Research and the JDR Clinical Translational Research, all sorts of online tools, our on-demand library, which are recordings of previous presentations, our IADR community where you can network online with members, awards and fellowships. This is our latest membership benefit, which we call the IADR community. We launched this shortly after we all went into lockdown with the COVID-19 pandemic. We had to cancel our 2020 meeting. We recognized that our members needed a forum to really network, which is what they missed by not having the meeting. So if you're a member, you can go onto this IADR community website and join a discussion, start a discussion either across all of IADR or to a specific scientific group or network or in a specific division or section. I mentioned the importance of advocacy. We have an international toolkit where we try to take some of the learning, particularly from our American division, which has been very successful at advocating for NIH and NIDCR funding, and how we apply that on an international basis and advocate for research funding with policymakers in your own countries or regions or with foundations. And there are tools within this toolkit, not to be redundant, that talks about how we can communicate, tell stories, et cetera. What are the real strategies to increase advocacy against oral health? First we have to get policymakers to understand why oral health is important, and then how research can help address the issues that are raised. Shortly after the pandemic, we also launched a COVID-19 resource page where we have publications, not only our own publications on COVID-19 and the JDR and JDR clinical translational research, but links to other publications. One of the nice things about COVID-19 is all the publishers sort of got together and said, nothing's going to be behind a paywall when it comes to COVID-19. So all of this is freely available to you, whether you're a member of IADR or not. The IADR, the American division of IADR, held a series of webinars in 2020 and also early 2021 on COVID-19. Those are all freely accessible to you. And we have information on research funding on COVID-19, most of it out of NIH and IDCR, but also other sources as well. So I would encourage you to go to that website. We are having our own virtual experience meeting next month, July 21 through 24th. And hopefully some of you are presenting and have registered for the meeting already, but you can also just attend the meeting if you have not submitted an abstract, and you can register today at IADR.org and go to our meetings page to register for that meeting. If you do happen to be based in a lower middle income country, we do extend a lower registration rate to our members in lower and middle income countries. That's really part of our core values, to make sure that our research findings get to places where it is needed in a more affordable manner. And all that information will be on our website. So that's really all I wanted to talk about today. And I wish you well for the rest of your Global Oral Health Summit. You can follow IADR on social media. We have a Twitter account at IADR, a Facebook page, Instagram, LinkedIn, YouTube, and you can find all the linkages there or on our website, IADR.org. I wish you well for the rest of the conference, and thank you very much for your kind attention.